Senator Cassidy.
Dr. Oz, I'll overlook the fact that behind you are some of my former staff members who have been stolen by the department from my department. So
they're well trained, sir.
I'll overlook that. Prior authorization, you're a provider. You know how sometimes care delayed is care denied. Speaking to a surgeon in Florida who said if he had gotten the prior auth like that, the surgery would have been less expensive, the rehab shorter, the patient's outcome better. Your thoughts, you're a provider, what do we do about prior auth issues in the Medicare Advantage program?
Senator Cassidy, thanks for your years of service to your patients and to the clinics that you've helped run and create, as well as service in the Senate. And I've enjoyed our conversations, numerous ones, about broad health care policy. This issue of pre-authorization is a pox on the system. We spend 12% of the healthcare budget on administrative costs. Pre-authorization is misused in some settings. There needs to be a mechanism to confirm that procedures are worthwhile, but I'll offer some ideas on how this might work. And if confirmed, I'd love to push some of these ideas and share them with other members of the committee. There are about 15,000 procedures that could have pre-authorization. They represent most of the things that are done. Not just operations, but medications that are given, et cetera. Insurance companies today use pre-authorization for about 5,500 of those procedures. But interestingly, not all insurance companies focus on the same things. And even within the idea that's the procedure that's being pre-authorized, the criteria for accepting it are also all over the place. So it's very difficult to automate that. And so it tends to be misused because it stalls the process, as your physician colleague in Florida pointed out, makes it more expensive, and we're spending money, wasting money, trying to do a process that should be automated. I would argue we could limit the number of pre-authorized procedures to 1,000. Be very clear, if you're going to have a knee replacement and you can bend your knee more than 120 degrees, you don't get the knee replacement, or whatever number you want to put in there. And then if we know those numbers ahead of time, like a credit card appropriate, credit card approval doesn't take you 3 months. You know immediately whether the transaction is approved or not. We will be able to do something similar so that pre-authorization could happen rapidly. And
let me ask you this then, because my docs will be so frustrated because they have previously gone through step therapy with the patient to get them, okay, this medicine didn't work, this medicine didn't work, this one didn't work, now this one finally does. Yeah. They change plans and they're being asked to go through step therapy once more, therefore giving the patient a valley of lack of response until they get to where they've already know they should be. Thoughts?
Senator Cassidy, that is one of the most frequent complaints I hear from physicians. Patients see it on the other side, which is I can't get the treatment. I'm in agony, I'm in pain. I really know what works for me, but no one will give it to me, even though I have insurance. Like, I'm part of Medicaid, I'm a beneficiary, I should be allowed to get access to this medication, which I'm told is in the plan, and yet it gets slowed down. This is a place where it's a matter of competency. This is not a Republican-Democrat issue. If we can do the job that's been assigned to us at CMS in a competent fashion and revisit some of the assumptions we've taken for granted for decades, that's being a good one, and use technology that today could help us. Because we have AI support tools, navigation systems that could pretty quickly adjudicate whether you should have to wait even a day to get the medication that will get you out of pain, or even a week for the procedure that you should be allowed to have. It'll take a lot of the angst out of the system for the American people. I mean, the healthcare executive.
I'm with you on that. I've got limited time. Let me ask you one more thing, or a couple more things, hopefully. There are local determinant decisions, a regional determinant decision. And Medicare is supposed to cover something unless it is said not to be covered. I'm told that there are MA plans which are reversing that and saying they will only cover something if there is a positive determination that it should be. I'm told this by pain doctors who say, wait a second, I can get the patient back to work, that sort of thing. Any awareness of that? Any thoughts of that?
I'm not aware that that was happening.
I'll bring that up to you. Lastly, we're both fans of MA plans, whatever the shortcomings, but there's some evidence they're getting anywhere from 106 to 120% of a group of similar Medicare patients who are not enrolled in MA. And now, as we look at the trust fund going insolvent and our budget deficit expanding, is this a place you would look, and if so, how would you look in terms of getting better value for the dollar?
So the MedPAC assessments have revealed what you just shared, that we're actually apparently paying more for Medicare Advantage than we're paying for regular Medicare. So it's upside down. And I think there are ways for us to look, for example, at the upcoding that's going on, that's happening systemically in many systems, in many programs, to make sure that people who are being appropriately paid for taking care of sick patients, but not for patients who aren't ill. So, for example, if someone's showing up at your home to figure out if you have a small plaque in your carotid, because they're going to charge a lot more to for the care of your plaque, which they're not actually going to do anything for, that's wrong. And I think we have numerous tools, but part of this is just recognizing there's a new sheriff in town. We actually have to go after places and areas where we're not managing the American people's money well. And if we can do that effectively, and both of us, I think, agree that there are opportunities to do that that are massive in scope, but they're also important emotionally for the program. You want people to have confidence in the program. The employees administering, the career employees administering Medicare, and the beneficiaries should all feel the system's working for them.
On the upcoding, we're out of time. Thank you, Mr. Chair. Senator Merkley and I have a bill, the No Upcode Act, that actually achieves that. So I think you're going to be confirmed, and we'll discuss that with you at a later date. Thank you.
Thank you. Senator Hassan.